There are 3.1 million New Yorkers without health insurance, and the number is growing, says a new study by the United Hospital Fund. We have it here, actually. Today, the Urban Agenda will examine just what this means for the state. I'm David R. Jones, president of the Community Service Society of New York, a not-for-profit organization that concerns itself with issues that affect poor people. Healthcare is one of those issues. Joining me is Kathryn Haslanger, the director of the Division of Policy Analysis for the United Hospital Fund. She is also a member of the state's Medicaid Managed Care Advisory Review Panel and on the board of Care for the Homeless. Welcome, Kathryn.
Thank you.
Well, tell us what the United Hospital Fund is.
Certainly. The United Hospital Fund, based here in New York City, is actually the country's oldest federated charity. It's a philanthropic and research organization that focuses on issues related to healthcare delivery, and particularly issues that relate to low-income neighborhoods.
Well, this report that takes up the issue of the uninsured, what is the magnitude of the problem? What are we facing with uninsured people in the state of New York?
As you said in your introduction, the numbers in the report are really staggering. We found that in 1996 there were 3.1 million people in New York State that didn't have health insurance. We came into this analysis because we knew from working with folks in low-income neighborhoods that the problem of the uninsured hadn't disappeared, although the discussion of the problem certainly had following the end of the national discussions about health reform. We were a little surprised to see how much the numbers had grown, that in 1991 New York looked a little better than the rest of the country, but by 1996 we looked significantly worse.
What would this mean? I'm an uninsured person. I show up at a hospital. I assume they ask for me to give cash.
That's right, and I think actually the first question is, you're an uninsured person and you have a health problem, what's the decision that you make about trying to seek care, and what do you think your options are? A lot of people think that if you have insurance, you're more likely to get care, but if you don't have insurance, you'll still get what you need. And actually the research from New York and from across the country shows that people without health insurance don't get what they need, that they are much less likely to get services when they need them, that they'll get less service, and that in fact when they do get treatment, they may not fare as well.
So if I'm an uninsured person who happens to be poor as well, and I have, I guess, need an appendectomy or something, where do I go? What do I have to do?
If your problem was something like you had an emergency need for an appendectomy, then you would go to an emergency room and you would be treated. You would obviously get what you needed in that circumstance. But think about a problem that is something like a chronic illness like asthma that can emerge in a variety of ways. If you had health insurance, you would probably have a doctor who was your usual source of care. You'd be getting some help on an ongoing basis in managing your condition. If you didn't have health insurance, you wouldn't have a place to go, and you would have to wait until you found yourself in an emergency situation or until your child was very, very sick before you could seek that emergency help. And that's not how we want people to get health care.
And when the emergency care, say, I have the operation, who pays for it? What happens there?
That's an important question, because we sometimes think about the problem of the uninsured as only affecting the people that don't have coverage. The person who's uninsured will, of course, get some kind of a bill. It will impose an enormous financial hardship on them, and they probably won't be able to pay it. That means that the institutions that provide these services are then faced with the financial strain of providing services to the people when they need them and not having the resources to pay for those services. And that's something that affects all of us, because we use those institutions too.
Now the state has a special pool of money. It used to be called the Bad Debt and Charity Pool. I've never got the new acronym. Doesn't the state pick up these costs for a hospital or something that treats somebody they can't charge?
New York State has been very progressive in many ways, and that's an important point, that there are these pools that make partial payments to hospitals in New York State.
It's not 100%.
No, the estimates are from 35 to 40% of the cost, and it varies by institution, so that the hospital's not made whole for the services that they do provide.
So where does the money come from?
Well, it probably comes from everybody who does pay for their services, from the regular Medicaid program, from all of us who have employer-sponsored coverage. There's a little bit extra that has to be built into that bill so that the hospital can continue to meet its costs.
And in the new managed care environment, where they're squeezing all the money out of some of these streams, is there much leftover money to cover this?
The facilities that provide the largest amount of service to the uninsured are really particularly feeling that strain, because the managed care companies are negotiating discounts from them. They're pushing the price down that they're paying to those places, so they have less of an ability to move the money around internally and to continue to cover their costs.
Give us a profile of who the uninsured are. What does this 3.1 million people, where are they? What are they doing? Do they work? Don't they work? Why aren't they on, welfare and getting Medicaid? What's going on with them?
We were surprised to see that in looking at the uninsured in New York, most of them are working, and many of them are working full-time. There are folks who are living at a roughly 200% of the poverty level or below. That means in New York City you'd be a family of 4 trying to get along on about $30,000 a year. So those are families that don't have a lot of extra money to spend either for paying for services or providing or trying to purchase some kind of insurance coverage. We thought it was really important to emphasize to people the fact that we were talking about low-income folks and we're talking about people who are working, because these are really people who are playing by the rules and losing. They've gotten a job, they're trying to be independent, and they don't have employer-sponsored coverage. Most of the people who have coverage get it through their job, get it through employer-sponsored coverage. But increasingly we're seeing for low-wage workers and for workers in small firms, the health insurance benefit isn't coming along with the job.
So it's not mandatory for an employer to have a health benefit?
No, it's not. And for many small employers that are themselves sort of on the economic margins, it's an expensive benefit for them to provide, and they've made the decision that they just can't do it. And so many of their workers then are uninsured. At the same time, they're employed and they're making a little bit too much money to apply for the Medicaid program, which covers very low-income New Yorkers. And that's the problem, particularly people who are in the middle between where the public program ends and employer-sponsored coverage picks up.
Did any of your research indicate that those people, the uninsured, someone making $30,000, who ultimately has a relatively simple operation but just can't afford it, do they get into real debt problems? Do we end up destabilizing, sort of stable families with this?
That wasn't an issue that we particularly looked at, but the Commonwealth Fund has recently done a survey of low-income New Yorkers, and they document in that survey the financial hardships for folks who don't have coverage and try to pay for their services.
Now, there's been obviously, everyone recognizes that welfare reform has swept the country, and people on welfare are losing benefits, going into work programs. What's the impact been on people who receive Medicaid, for instance?
That's a particularly important point because the work that we did looked at what was going on through 1996, and much of the impact of welfare reform has happened since then, so that we're expecting when we take another look at these numbers that we will see further declines, and that we'll see those declines particularly among the very low income and in low income workers. What we understand to be happening with welfare reform is that there are a lot of messages that are going out that families are being discouraged from coming to apply for cash assistance, and that was the primary mechanism that people use to get the health insurance benefit that the Medicaid program supplies. So with fewer people coming in, with more conditions being placed in their participation in the cash programs, the work requirements, etc., there are many, many fewer people getting Medicaid, and those numbers have declined steeply in the last 2 years.
Well, I think this was a subject of some recent news reports criticizing the city of New York for essentially not only taking people off welfare, but also denying them food and health benefits.
It seems important to us to think about the Medicaid program as a health insurance program. This is a work support. This is something that can help a family be independent. It's going to be very hard to get a job and keep a job if you have health problems that you can't attend to, or if you have a child with a chronic illness and you're having to take them to the emergency room for an asthma attack and you don't have the ability to get regular ongoing primary care.
Well, talking about children, isn't the state of New York has Child Health Plus? Isn't that supposed to relieve us of all these problems?
The Child Health Plus program is a terrific program, and it was expanded to cover even more kids and cover even more benefits in some legislative action in Albany last July. That's a terrific thing. That's going to make a really big difference for kids.
Right.
Unfortunately, it won't cover their parents, and most of the people in New York who don't have health insurance are adults.
But have we seen any signs that Child Health Plus is picking up children, at least, in this engagement?
It's very early to tell, but certainly the monthly enrollment numbers are showing that there are more and more kids that are entering that program. Unfortunately, there are also more kids and adults that are losing coverage because of the welfare reform and the Medicaid declines that we were just talking about. So that we end up taking steps, going forward, doing new things. At the same time, the number of uninsured seem to still be rising.
Now, New York City, along with Texas, I guess, and California, has, I guess, the largest numbers of documented and undocumented aliens coming in. There was specific attacks on providing not only welfare benefits, but health benefits to immigrants. Have we seen anything of that? For instance, how many of the uninsured, in your view, are immigrants who may not be entitled anymore to Medicaid, or certainly the traditional Medicaid.
I think that's a very serious problem in New York State, and particularly in New York City, because as you said, new immigrants who've entered the country after August of 1996 aren't eligible for the programs anymore, and we're expecting that in the next round of numbers we'll probably see some further decline in coverage.
As we see the issues rolling out, of course, universal health care has been made sort of anathema. No one wants to touch it anymore. Do you think that, based upon your report and the growth in the number of uninsured, we're going to have to come back to revisit this? We
certainly need to come back to a very serious national discussion. Our assessment at this point was that we thought it was important to try to get this state discussion going, because we're looking at some opportunities in the next year in New York as the healthcare reimbursement legislation comes up for reauthorization.
Let's talk about that. How does that work? I think nobody except the sort of people who are focused on this know about that.
There are decisions that New York State makes every 2 or 3 years about how hospitals are going to be reimbursed, about the subsidy pools that you described that help hospitals pay for the care for people who don't have coverage, and those discussions are going to be starting again in Albany next spring. And we think that that's an opportunity to talk about the growing number of uninsured and the range of strategies that the state could employ to do something about that decline in health insurance coverage. Remember that in the late 80s and early 90s, New York was an innovator with the Early Child Health Plus program, and that program fared well here and then became part of a national discussion that resulted in a very large national resource being available for kids' health insurance from Washington, and has facilitated the further growth in the Child Health Plus program. So we'd like to think that maybe that could happen again, and that New York could be a leader in putting the issue of the uninsured back on the agenda. That is to say, there are some things that we can do at the state level to start taking steps to address the problem, and we would like to see New York take those issues up in the next year.
Well, let's take, obviously your report would indicate that simply reauthorizing the bad debt and charity pool, or the reimbursement pool the way it is, might not be sufficient.
The pools are an important resource, and we certainly wouldn't want to see them diminished or taken away. At the same time, it seems like there are many other things that the state could do, and in thinking about what those strategies might be, there are a couple of things that we thought were particularly important to emphasize. The first was, as we were saying, let's have a conversation about what we can do at the state level. It would be terrific to have a national discussion. It doesn't feel like we're there right now. So that takes off the table some of the things that are really best done from Washington. I think universal health care is probably one of those. At the same time, we think the strategy should focus on what happens to low-income individuals. This is a problem that we said is largely concentrated among folks who are making less than $30,000 a year and don't have resources to buy coverage or to buy services. We think that people should be talking about, in this expansion, providing a package of benefits that's comparable to what people get through their employer-sponsored coverage. It shouldn't be something that's just catastrophic or just so bare bones. The experience from other states is that people just don't buy those things. Those aren't successful strategies to embark on. And finally, it's really important to make sure that people can contribute to their insurance premium or to their care, but those contributions have to be affordable. And the other thing that we know from what other states have done is that once you take those contributions above a fairly small amount, people don't enroll. They just can't afford it, and that's another design feature to keep in mind.
Clearly, when we deal with particularly people who are transitioning from welfare to work, even when they're offered insurance plans, basically it comes between eating and housing, and healthcare always takes a back seat.
That's right, and increasingly employers are asking employees to contribute more so that they can participate in whatever the plan is that the employer is offering. And that's an affordability decision that families are making and finding that they just can't afford it. But I think it's also really important to go back and to remind folks that even if the lowest income families were making those same decisions about insurance offers that other workers are making, even if they were accepting them as often as they could, that would make very, very, very little difference in terms of the number of uninsured. The issue is really that low-wage workers and workers in smaller firms aren't offered insurance, and that's what the difference is. And that's something that has been an increasing problem even during a time when the economy has been doing pretty well, when job growth has started an upward trend again in New York. So this feels to us like a problem that we're not just going to grow our way out of. It feels like a structural problem that requires a public policy solution.
Getting back to the demographics of the uninsured, are they, clearly Child Health Plus takes care of the kids. Does Medicare cover all the elderly on the other end?
Medicare covers the vast majority of the elderly, and so the problem that we've really focused on is among folks who are younger than 65, who don't yet qualify for the Medicare program.
So this is 18 to 65?
Yes.
Okay,
Yes.
so these are literally people in their most productive years. Anything else that surprised you? Is you were one of the authors of this report, I should note, not just representing United Hospital Fund, but actually helped write this. What surprising started to emerge that just wasn't known?
I think the things that were striking to us were the number of people who are working and working in low-wage jobs and even working full-time. We hear a lot about contract workers and part-time workers, and that's certainly a part of the problem. Mm-hmm. But a very large number of these folks are people who are really working full-time and are still not making not getting health insurance as part of their compensation package, and certainly aren't making enough money to buy it on their own. And that was the thing that was really striking to us. I think the other point that we were struck by was the very large number of people who look like they would qualify for one of the public programs but are not enrolled. They look like somebody who could qualify for Medicaid, but they don't actually have a Medicaid card. Mm. And so one of the things that we would like to see people paying more attention to is increasing the enrollment in the Medicaid program and in the Child Health Plus program for the kids, for the parents and adults who are eligible.
Now, I just came off the Health and Hospitals Corporation board, and in my last year of tenure, we were beginning to recognize an astronomical increase in the number of uninsured showing up at HHC facilities. HHC obviously is different, that it provides care no matter what, without respect to ability to pay. Do you see any of that? Is there a question of, can the municipal hospitals, separate from the voluntaries and others, survive if the numbers of uninsured continue to grow at this rate?
The uninsured pose an incredible burden for the municipal hospitals, and it is a real strain on their resources. And it's not just the hospitals, but it's also the neighborhood health centers, okay. Not just the clinics and the outpatient departments that are actually part of the inpatient facility, but almost more important are the health centers that HHC sponsors that are out in the neighborhoods that are really more like a family doctor. And those places do a very large proportion of the care of services to the uninsured.
Talking about another question, in your survey and report, where is the big cost here? Is it people coming up for just sort of routine care, or is it that catastrophic, problem, whether it's, I don't know what, a major injury, cancer, whatever people can imagine can go wrong?
The report really didn't look at that issue in particular. That we know from some other work that we do with the United Hospital Fund tracking the financial condition of hospitals in New York, and also some work with ambulatory care providers. We know that by and large, when it comes to a big, expensive, long hospital stay, the Medicaid program is probably going to take care of that. And the issue about services to the uninsured is much more of an issue for ambulatory services, for primary care, for the things that a lot of people go to their family doctor to see.
But if I have chronic diabetes or something like that,
the problem the problem for someone with chronic diabetes is that until something very serious happens that lands them in the hospital with a very, very serious illness, they're not going to have the ability to see somebody in a primary care setting or a doctor's office to follow them and to help them through on an ongoing basis.
What about drug regime? I mean, clearly drugs in certain categories cost astounding amounts of money. How does that get handled?
And even drugs that don't cost a lot of money. And one of the things that we know from looking at ambulatory care providers is that while many health centers and hospital outpatient departments have a sliding fee scale, and they make some provision for people who don't have health insurance coverage, many facilities don't make provisions for helping people get their prescriptions filled. So my son could have an earache, and I could take him into a place that was willing to see people without health insurance, and he could see a doctor, but we wouldn't necessarily have any help in getting the prescription filled so that he could have the medication that he needs in order to actually get well and get back to school.
So there's a real possibility that people just say, I can't afford it.
That's right.
That's
right.
Let's get into how to fix it. Let's talk about some of the things that your report suggests to try to cope with this. First at New York, and then I think it's a recognition that this seems to be a national problem as well.
That's right. That's right. One of the important first steps that we can take is just to get more out of the public programs that we already have. We have a Medicaid program with a comprehensive benefit structure, and we need to do a better job of getting people enrolled and participating in that program. And that has to do partly with public information, with making sure that people know that Medicaid is separate from cash assistance. And even if you're not eligible for cash assistance anymore, or you're not going to try to go to a welfare center to get a cash benefit, you can still get Medicaid, and that's a separate set of rules, and we need to make sure that people know that. At the same time, we think there's probably a lot of work that could be done looking at the mechanics of how the eligibility decision is made and what kind of documentation is required. There are other states that have gone toward mail-in applications. New York still requires people to come to a welfare office during business hours for an interview, so that there are sort of mechanics that we think could be streamlined and changed to make it easier for people to participate.
Actually, I think the city has started home visits to investigate people's closets to see if they really were entitled as well. I think that ended really quick. What about getting private employers better positioned to provide reasonably cost health insurance?
I think that there are a number of things that could be done. New York State has a small demonstration project that provides subsidies to small employers who are interested in offering health insurance but don't feel that they can cover the whole cost. That demonstration program was fully subscribed very shortly after it started. So, but it's very, very small. That's the kind of thing that could perhaps be grown, but it would have to be grown many, many times to make a dent in the number of employees in small firms that don't have coverage. There's an initiative that the city is undertaking to try to form a purchasing alliance to make it administratively easier for small businesses that want coverage. That's not something that's going to subsidize it or make the premiums cheaper, but it will make it less of a burden. And it's in a small firm that doesn't have a full-time human resources department, just negotiating the ins and outs of trying to figure out a health insurance plan for your employees and get them signed up and make it work is a significant administrative struggle, and the mayor's initiative would address that, and that's an important step.
Now, can you give our viewers some notion? I mean, when you talk about health care, you talk about huge sums of money. How much would it cost to start to deal with this problem in a serious way?
We took a range of estimates in our report, and we were looking at everything from just doing a better job getting people signed up in the existing programs, to expanding some of the existing public programs, to doing big expansions of the very small demonstration projects that are now making subsidies available for businesses and for individuals. And those options were really designed to take big bites out of the problem. So we were talking about, in some cases, 500,000 or nearly 1 million people that would be helped by this strategy. We were also sometimes talking about cost estimates that went up into the billions, or at least over $1 billion. Those are staggering numbers, but we thought it was really important to introduce that B word into the discussion so that people understood this wasn't a small problem that could be solved for a nickel on the margin, that it was something that was going to require a substantial commitment of resources.
And did you get any sense, obviously you can't predict, of what the level of growth will be? We're at 3.1 million now. If nothing changes, can we expect those numbers to grow by 50%, 100%? What happens if we hit a recession? I'm throwing these at, we're all speculating here, but what are we facing in the state of New York?
I think that we are really concerned about where these numbers are going because, as I said, we've seen a decline in employer-sponsored coverage, which is the main way people get coverage. We've seen a decline during good economic times. And this snapshot that we took that found 3.1 million uninsured was taken before many of the effects of welfare reform were put in place. So if you add the impact of welfare reform and the big declines in Medicaid with an expected continuing decline in what employers are doing, we are quite certain that when we take another look at these numbers, we'll see them going up. Certainly not by the order of magnitude that you were suggesting, but an already very sizable problem is going to grow more significant.
And what arguments should we use to convince the general public, already hard put with taxes, that this is an important investment, other than, you should help people who can't do it? Are there any potential impacts on the state economy if we don't do this? Are there?
I think it's in all of our interests to have to live in communities where people are working and where people are able to work and to contribute and to be independent. And having health insurance is something that helps you do that. Not having health insurance and having to deal with problems only when they become very serious and then become more complicated means lost days from work, lost days from school, developmental problems in children that don't get addressed, and those are all things that have long-term costs that society is going to have to bear.
Can we look to other parts of the nation or other countries where they're doing a better job at handling this?
The other perhaps surprising thing for us, because we like to think about New York as a progressive place and a place that's on the cutting edge, was to find that there were 2 other states who had very significant programs that were available to adults, not just parents or not just people who were very, very low income, but adults up in the same range of $30,000 a year or above that we were talking about as being the locus of the problem in New York. The state of Washington, the state of Minnesota, both have taken big steps to expand insurance coverage in their populations.
They have a wrestler as governor, and who knows what's next. And what are the distinctions? How did they fund that? How did they get their legislators to go along?
There's some other states that have done big expansions. For example, the state of Tennessee,
right.
They did it through a Medicaid expansion. It was a waiver and agreement that they made with the federal government
right.
about moving their entire Medicaid program into managed care and taking the savings to expand coverage to people who were above what the old Medicaid program would have covered.
Now, we haven't talked about the HMO issue and managed care. Does it fit with the uninsured?
Well, I think people are, as people are talking about insurance expansions, they're generally saying, if we expand benefits, we want to make sure that it's done in the most cost-effective way possible, and for most people that translates into a discussion about managed care. But certainly the pressure that the managed care companies are bringing on the rates that they're paying to providers mean that the providers are having a great struggle providing services to the uninsured, and that might make access to care even more difficult going forward.
Are there any potential taxes or other things we can look at that people might find? Cigarette taxes? I don't.
In other states that have done expansions, they have looked to alcohol taxes or cigarette taxes. I think in New York there's going to be more and more attention paid to the tobacco tax and where we are compared to some of our neighboring states, and some folks are looking to that as a potential revenue source. We are open about where the revenue comes from. State and federal sources, employee contributions, employer contributions, all of those things need to be part of the discussion. The important point for us is that people start having the discussion in a serious way so that we can craft a program that makes some progress on the problem.
Mm-hmm. This report takes in the whole state or just the city?
Yes.
So this isn't just a New York City...
This is not just a New York City problem. It's an upstate problem as well. Certainly the problem is more concentrated in the city. The lack of employer-sponsored coverage is more serious in the city, but it's not just a downstate issue.
Thank you very much. Like food and shelter, health care should be a right of citizens in a developed country. Everyone, rich or poor, should have access to medical care for themselves and their children. This would benefit not only the individuals covered, but the rest of society too. If we don't provide access to health care, we run the risk of epidemics like tuberculosis once again sweeping the city, as they have in the past. Doesn't it make sense, both for public health and public expenditures, to invest in comprehensive health care before there's a crisis? I'm David R. Jones for the Urban Agenda. Thank you for joining us today.
To comment on the Urban Agenda or for more information on CSS, contact Community Service Society of New York, 105 East 22nd Street, New York, New York, 10010. Area code 212-254-8900.